Good morning. We're going to talk about mental health neurocognitive disorders, chapter 23. These are conditions where the brain's no longer functioning the way it used to. This includes things like delirium and dementia. So as nurses, we must be able to recognize the difference quickly because one is often reversible and one is not. So our objectives are basically going to be focusing on delirium versus dementia in nursing care. Delirium's clinical picture. Sudden hours to days is the onset. It fluctuates, it comes and goes. Delirium is an acute change in the mental status, and the biggest clue is inattention. They cannot focus. So this is not normal aging. It's a medical emergency unless proven otherwise. If your patient was fine yesterday and today they're confused and seeing things, that's delirium. And this is common in hospitalized patients, especially our older population. So let's look at the slide and these things that's listed. Disturbance in attention. They cannot focus or stay on task. You ask a question and they start answering something completely unrelated. Abrupt onset with periods of lucidity. Happens fast. Delirium with the sudden onset. One of the most important clues is fluctuation. The patient may be alert one minute and then confused the next, and the family says, well, they were fine yesterday and now they're confused. So the fluctuation. Disorganized thinking. Thoughts don't make sense. They ramble. They're illogical. They cannot connect their ideas. They may jump from one topic with no logical to another one with no logical connection. Disorientation, they don't know time, place, sometimes person. This reflects the acute brain dysfunction. So as nurses, we should always be doing a good assessment and always assess orientation to person, place, time, and situation. Anxiety and agitation, they may become restless, pulling on their lines, trying to get out of bed. Because the patient cannot understand what's happening, they often become anxious or agitated. Poor recall, cannot remember what just happened. Short-term memory is impaired. This might be due to the brain processing. You just told them something and seconds later they don't remember what you just said. Delusions and hallucinations, seeing things that's not there, like bugs on the wall, people in the room. This is called tactile hallucinations, and you want to remember that, and we don't tell them that the bugs are not there, for example. If they say, oh, there's bugs in my room, then you don't want to say, no, there's not. You want to say, I don't see those bugs, but I'm here to stay. I'll stay with you and support you. So you want to remember that. So hallucinations in delirium is often visual, which is different from schizophrenia where they're auditory. So that'll help you distinguish between those two. So risk factors, it often occurs because something in the body's disrupting the brain function. The brain is extremely sensitive, so even small physiological changes can lead to confusion. So some common causes would be possibly UTI. How many of you been working with the elderly? They get a UTI and they become confused. That's one of the most common causes of delirium, and so that's something we would be assessing. Dehydration, dehydration reduces blood flow and oxygen to the brain, which can quickly lead to confusion. So, and this is especially common in our older adults, again, because they don't get thirsty. Medications, sometimes multiple drugs are used together when they shouldn't be, so that's why we're doing a good medication assessment and not just checking them off and going over them like we should. Medications can alter those neurotransmitters and impair their cognition, so good medication reviews. Sleep deprivation. Sleep is essential for brain function, for sure. So a lack of sleep disrupts the normal cognitive processing and can worsen or trigger delirium. So overall assessment, just what you're really doing, you're detecting those acute changes. You do not want to assume confusion when it's delirium or dementia, I'm sorry. One of the biggest mistakes in nursing is assuming confusion in older adults is dementia. So we always ask, is this new? Is it sudden? And if it is, then think delirium. So it fluctuates. Like I said before, the patient may look fine at 10 a.m. and confused at 2. This slide just reiterates kind of what I just said. Do not assume confusion is dementia in the older patient. Identify disturbances in their physiological status, assess their vital signs, level of consciousness, assess for a potential for injury, and you can read the rest of them on this slide. So all of these nursing diagnoses point to one priority, and that's the patient is at risk for harm. So when the brain's not working, safety becomes our #1 priority. So I'm just going to briefly go over some. Risk for injury, that's when they wander, have unsteady gait. They may act out of fear from hallucinations. They forget things like leaving the stove on and things like that. They may be falling. If their sleep is impaired, they may be awake and disoriented through the night. Self-care deficit, they may not be taking care of their basic needs, nutrition, fluid intake, things like that. Anxiety and panic, they may have, or fear due to things they may be seeing. Another one would be confusion. It says here acute confusion. So just basically does not recognize people, places, things like that. And impaired communication, they have difficulty with their speech and cannot find words. The nursing process continued. Basically keep them safe, reorient them, maintain hydration and nutrition because our outcomes are very practical. Keep the patient safe, keep them oriented, and support the body while we fix the underlying cause. Nursing process continued. One thing I want to point out here is you would not want to use restraints that could worsen their situation. They should always be avoided because it would increase their confusion, and instead we use calm presence, reorientation, and treat the underlying cause. You don't treat delirium, you treat what caused the delirium. Mild and major neurocognitive disorders. This is dementia. So unlike delirium, dementia is a chronic and progressive disease. This patient does not have changes in consciousness. They're awake, but their cognition is declining. So think of it this way. Delirium is acute and reversible, and dementia is chronic and progressive. So I'm going to go over some of the things on the slide. It says, recognize the clinical picture of mild and major neurocognitive disorders. So mild would be slight memory issues and still independent. Major would be like significant decline and cannot function independently. So when we recognize, we mean you should be able to look at a patient and identify whether what you're seeing is mild cognitive change or a major neurocognitive disorder like dementia. And this is critical for early detection and intervention. Then our slide says, describe the clinical picture and progression of Alzheimer's disease. Early on Alzheimer's is memory loss. That's scary. Middle is confusion, behavior changes, and late is total dependence. So describing Alzheimer's means understanding how the disease progresses over time from mild forgetfulness to severe cognitive and functional decline. This is a progressive, irreversible disease, so recognizing early signs is key. And then the slide says give an example of apraxia, agnosia, and aphasia. So apraxia, they cannot perform tasks like can't brush their teeth even though they're able to. Agnosia, it can't recognize objects. For example, they may not recognize that a spoon is a spoon. And then aphasia, more commonly known, language problem. Example, they cannot find words or understand speech. And on this slide, I think I got ahead of myself, so we'll just move to the next one. The DSM-5 basically declined from the baseline and they're still independent. Mild neurocognitive disorder means something's changing, but the patient can still function independently. So basically just look over that slide. Here's some various cognitive disorders, many causes, but Alzheimer's the most common. Alzheimer's is the most common cause, but remember, stroke, Parkinson's, and brain injury can also cause dementia. So these are all causes of major neurocognitive disorder, but each one has a slightly different pattern of symptoms. I'm going to talk some about Alzheimer's disease. Sad disease, very much so. It is a slow brain degeneration. The progression is mild forgetfulness, as we talked about earlier. Moderate starts the confusion, and severe is total dependence. Alzheimer's is progressive and it's irreversible. It starts with memory loss and ends with complete dependence. Very, very sad disease. Symptoms of Alzheimer's disease. Please make sure you understand these. Memory impairment, difficulty forming new memories. They're often repeating questions or forgetting recent events while their long-term memory may still remain intact. If you've ever known anybody with Alzheimer's, you've seen this, I'm sure. This is usually the first sign, is the memory impairment. Patients can't remember what just happened but may recall things from many years ago. It's quite amazing. Disturbances in executive functioning. This is impaired ability to plan, organize, or problem solve and make decisions. Patients may struggle with things like finances, cooking, or just basically following a sequence of steps or steps and procedures. Aphasia, loss of language ability. They have difficulty speaking, understanding, or finding the right words. They may pause mid-sentence and use the wrong word, or they may have trouble understanding what's being said. Apraxia says loss of purposeful movement. That's the inability to perform learned tasks despite having the physical ability to do so. They can move physically, but they can't remember how to perform tasks like maybe brushing their teeth or getting dressed. And then it says agnosia, loss of sensory ability to recognize objects. They may recognize familiar objects or people or sound despite intact sensory function, but they may look at a spoon and not know what it is or fail to recognize a family member or even a spouse. Again, very sad. So the risk factors, most common is that late onset and female. Women affected more because they have a longer lifespan, and it is saying that it's possible hormonal factors as well. Most cases occur after the age of 65, and so Alzheimer's disease is a most commonly late onset condition, meaning it develops after age 65, more common in women, partly because they live longer, and as the population ages, we're seeing increasing rates of Alzheimer's. Biological factors, genetics, certain genes increase the risk, especially in early onset Alzheimer's. So genetics do play a role. Cardiovascular disease, poor blood flow to the brain, contributes to cognitive decline. Conditions like hypertension, diabetes, and heart disease can damage the blood vessels in the brain, increasing the risk for dementia. Just remember, what affects the heart affects the brain. Head injury and trauma. Traumatic brain injuries can lead to long-term changes in brain structure and function. And then the modifiable risk factors. Now, these are things that we can change or improve. Exercise and sleep, physical activity, and good sleep support brain health. So regular exercise improves the blood flow to the brain, and adequate sleep helps with memory consolidation and brain repair. Very important. That's why we've always heard it's good to get a certain amount of hours of sleep. Social engagement and diet, staying socially active and eating well protects cognition. People that become reclusive and don't go out of the house and things like that, that puts them at a higher risk because they need that social activity. It keeps the brain active, while a healthy diet rich in fruits and vegetables and healthy fats supports brain function. So that's something that we can do something about. And then it says education and mental stimulation. Lifelong learning and mental stimulation help build what we call cognitive reserve, which may delay the onset of symptoms. In other words, you hear the old adage, use it or lose it, and that is so true. So some risk factors like age, genetics, we cannot change, but others are modifiable. This means we have an opportunity to reduce the risk through our lifestyle choices. Okay, so non-modifiable, age and genetics. Modifiable is exercise, diet, sleep, social activity, and mental stimulation. Good tips there. So application of the nursing process. Number one, confabulation is a creation of stories in place of missing memories to maintain their self-esteem. Number two is preservation. The patient repeats the same words or questions or actions even when they are no longer appropriate. Agraphia, number three, is the patient gradually loses the ability to write or understand language or written language. Hyperorality is the tendency to put everything in their mouth. And then aphasia, apraxia, agnosia, we've already talked about these. These reflect progressive loss of language, movement, and ability to recognize objects or people. And then sundown, and you want to know this one, the patient becomes more confused, anxious, and agitated in the late afternoon or evening. So patients are not lying when they confabulate. They're trying to make sense of memory gaps. And then, like I said, sundowning happens because the brain struggles more when environmental cues like light decrease. Just more of the application of nursing process. Some tests that may be obtained during the nursing process: diagnostic tests, CT scans, PET test, mini mental exam, complete physical and neurological exam, complete medical and psychiatric history needs to be obtained during your nursing process, and then review of recent symptoms, meds, and nutrition. And there is no single test for Alzheimer's. We rule out other causes and then assess the cognitive decline over time. Assessment continued. So we're going to evaluate their current cognition level, identify and address any threats to their safety, including their home. There may be things in the home that would be unsafe, so a home evaluation is important. Reviewing their medications, and interviewing family to assess preparation and coping. So many times the families are not prepared for what's coming with Alzheimer's, and it's, like I said, it's a very painful disease. It's very hurtful to the family because sometimes the patient's saying things that they would have never said before. They would do things they would never do before. The family absolutely needs to be prepared, and so many times they are not. We review available resources when they're having struggles. They may need to, the family themselves may need to attend a support group so they can understand what to expect. And we need to identify teaching and guidance needs, especially regarding the sundowning. So self-assessment, a realistic understanding of the disease, and stress management, caregiver support is huge. In dementia care, you're treating two patients, the patient and the caregiver. And like I said on the last slide, support and educational resources are imperative, and we need to maintain good self-care. It can be very stressful as a nurse taking care of these type of patients. Some nursing diagnosis I'll share: safety due to the wandering, communication, and caregiver stress. And again, caregiver stress is just as important as patient care because burnout is extremely common. I think I got ahead of myself on this slide, so here's some more of the nursing diagnosis if you'd like to read those. Pharmacological treatments for Alzheimer's disease. We will talk more about that when we talk about the meds. So outcomes and planning, it's a person-centered care. We focus on maintaining dignity, safety, and quality of life, not curing the disease. Community support, nurses must connect families to resources because dementia care is long-term and overwhelming. I'm not going to read all that's on this slide under treatment modalities. I'm just going to wrap this up and say these medications do not cure Alzheimer's. They only slow the progression. Antipsychotics are used cautiously because they will increase mortality in older adults. So just please look over that slide for your knowledge. Okay, so before we finish, tell me this. If your patient becomes suddenly confused, has an unsteady gait, slurred speech, what's going to be your first concern? And I hope you all said delirium and then find the cause. Okay, hope this helped, and see you guys soon.